Good morning, students. Today's lecture topic is chronic obstructive pulmonary disease. COPD. It is a disease state characterized by airflow limitation that is not fully reversible. The airflow limitation is usually progressive and associated with an abnormal inflammatory response of the lungs to noxious particles or gases. COPD includes chronic bronchitis, emphysema, small airway disease. COPD is the fourth leading cause of death in the USA. Risk factors. In the West, most important is cigarette smoking. In developing countries, role of household fuels and indoor pollution have important contribution. Occupational exposure, air pollution, genetic A1, antitrypsin deficiency. Regarding smoking, the degree of damage to the lung FEV loss is proportional to the amount of cigarettes smoked. Not all smokers develop COPD, 15% only, outlining individual susceptibility. Second-hand passive smokers are also at risk. Regarding asthma and COPD, Dutch hypothesis, asthma and COPD are two diseases in the same spectrum. British hypothesis, different entities. COPD and asthma are different diseases. COPD affects elderly, especially smokers, and asthma affects all ages, especially childhood. COPD is slowly progressive. Asthma is episodic course. COPD is inflammatory cells, neutrophilic bronchitis, eosinophils during exacerbation, as well as asthma has inflammatory cells, eosinophilic bronchitis, neutrophils, and severe disease. COPD is partially reversible and asthma may be fully reversible. COPD airway remodeling and lung destruction. Asthma airway remodeling, no destruction. Natural history. Risk of mortality from COPD is closely associated with reduced level of FEV1. FEV1 is a marker of obstruction. Obstruction leads to hyperinflation. Hyperinflation leads to impaired diaphragmatic function. Pathology. Cigarette smoke exposure may affect the large airways, small airways, 2 mm diameter, and alveolar space. Large airway changes cause cough and sputum, that is the symptoms. Pattern. Emphysema. It is defined in anatomic terms. It is destruction of the airways, expand or century acinar pattern. Chronic bronchitis. It is defined in clinical terms. It is based on symptoms. Diagnosis. It considers COPD in any patient with combination of the symptoms, that is, dyspnea, chronic cough, chronic sputum production, history of exposure to risk factor. Physical examination is rarely diagnostic in COPD. Wheezes here and there with severe airflow obstruction, use of accessory muscle of respiration in tripod position, cyanosis, system wasting. Later on, signs of right-sided heart failure, sometimes features of systemic inflammation, that is ischemic heart disease, osteoporosis, poor sleep. Laboratory finding, CXR can be normal or sometimes shows some hyperinflation. It don't rule out COPD. You have a normal CXR. Pulse function test, low FEV1 by FVC, low peak flow. Some reversibility might be there in the obstruction. HCT for erythrocytosis. ECG and echo for cor pulmonale. Stages of COPD. We use spirometric parameters, gold staging. Stage and severity with that definition you can see in the figure. All stages from mild, moderate, severe to very severe. Management plan has four components that are assess and monitor disease, reduce risk factors, manage stable COPD, and manage exacerbation. Assess and monitor stage of the disease. Use spirometry and clinical features. Risk factor reduction is smoking cessation. Stable COPD needs bronchodilators, anticholinergics, beta agonist. Inhaled corticosteroids for patients with frequent exacerbations. Vaccination, influenza and pneumococcal. Non-pharmacotherapies. Pulmonary rehabilitation, lung volume reduction surgery, and lung transplantation. Treatment of exacerbation. Exacerbation are a prominent feature of the natural history of COPD. The frequency of exacerbations increases as airflow obstruction increases. Exacerbations are commonly considered to be episodes of increased dyspnea and cough. Its treatment includes bronchodilators, antibiotics, glucocorticoids, oxygen therapy, and mechanical ventilation. Bronchodilators are a type of medication that make breathing easier by relaxing the muscles in the lungs and widening the airways, that are bronchitis. There are four bronchodilators, beta 2 agonists such as salbutamol, salmeterol, formoterol, and vilanterol. Anticholinergics such as ipratropium, tiotropium, aclidinium, and glycoprenolium. Next is antibiotics. Antibiotics are the medicine which is used for destroying bacteria and also curing of infections. Glucocorticoids are steroids, hormones widely used for the treatment of inflammation, autoimmune disease, and the cancer. To exert their broad physiological and therapeutic effect, glucocorticoids binds to the glucocorticoids receptors, which belongs to the nuclear receptor superfamily of transcription factor. For example, among the most common one are cortisone, that are a shot that can ease inflammation in your joint, prednisone and dexamethasone pills that treat the allergies, arthritis, asthma, vision problem, and many more conditions. Triamcinolone is a cream that treats the skin condition as well. Next we do have is oxygen therapy. Oxygen therapy is a treatment that provides you with extra oxygen to breathe in. It is also called supplemental oxygen. It is only available through a prescription from your healthcare provider. You may get it in a hospital, another medical setting, or at home. Some people only need it for a short period of time. There are four types of oxygen therapy, which includes oxygen gas, liquid gas, oxygen concentrators, and hyperbaric oxygen therapy. Now comes mechanical ventilation. A mechanical ventilator is used to decrease the work of breathing until patients improve enough to no longer need it. The machine makes sure that the body receives adequate oxygen and that carbon dioxide is removed. This is necessary when certain illnesses prevent normal breathing. The two main types of mechanical ventilation include positive pressure ventilation, where air is pushed into the lungs through the airways, and negative pressure ventilation, where air is pulled into the lungs. Home oxygen therapy for resting and nocturnal hypoxemia and lung volume reduction surgery. Here you can see the figure from mild to very severe condition of COPD. Next is asthma. Asthma is a syndrome characterized by airflow obstruction that varies markedly both spontaneously and with the treatment. Narrowing of the airways is usually reversible, but in some patients with chronic asthma, there may be an element of irreversible airflow obstruction. Prevalence is up to 10 to 12% of adults and 15% of children affected by this disease. It can present at any age and peak age is 3 years. Children with asthma, the asthma can subside as they grow older. Adults with asthma rarely so. The severity of asthma does not vary significantly within a given patient. Etiology of asthma. Asthma is a heterogeneous disease with interplay between genetic and environmental factors. Genetic predisposition suggested by familial association of asthma, high degree of concordance of for asthma in identical twins. The severity of asthma is also genetically determined. Environmental factors in early life determines which atopic individuals become asthmatic. Atopy is the major risk factor for asthma, that is allergic rhinitis and atopic dermatitis. Allergens, house dust mite, intrinsic asthma or non-atopic asthma, that is 10% have negative skin test to common inhalant allergens and normal serum concentrations of IgE, usual adult onset. Pathogenesis as asthma is associated with a specific chronic inflammation of the mucosa of the lower airways. The degree of inflammation is poorly related to disease severity and may be found in atopic patients without asthma symptoms. Its clinical features include wheezing, dyspnea, and cough. These are variable both spontaneously and with therapy. Symptoms may be worse at night. Typical physical signs are inspiratory and to a great extent expiratory, bronchitis throughout the chest. Physical signs are wheezes. Its diagnosis simple spirometry confirms airflow limitation with a reduced FEV1, FEV1 by FVC ratio, and BEF. Reversibility is demonstrated by below 12% or 200 ml increase in FEV1 15 minutes after an inhaled short-acting beta-2 agonist or in some patients by 2 to 4 weeks trial of oral. Aims of treatment. For the patient to have no or minimal symptoms, especially nocturnal, no emergency OPD visits, no frequent use of salbutamol, no limitations of activity. Its treatment include two groups of drugs are used, which are bronchodilators, beta-2 adrenergic agonist, anticholinergics, and theophylline controller glucocorticoids, antileukotrienes, hormones, anti-IgE, immunotherapy. Management of chronic asthma includes avoid triggers, pharmacotherapy, stepwise therapy, patient education, and goal is to reduce the impairment. Treatment of chronic asthma. First, try to determine severity. This can be done by looking at reported symptoms over the previous 2 to 4 weeks. Night symptoms include current level of lung functions, FEV1 and FEV1 by FVC values, number of exacerbation requiring oral glucocorticoids per year, and emergency visits. This stratify your patient by the severity to either intermittent, mild persistent, moderate persistent, and severe persistent, and then institute therapy by the level of severity. This is the classification of asthma severity. You can see in the picture the components of severity. Adjusting therapy. It assesses the status of the patient after 2 to 4 weeks of therapy. If improving, step down the treatment. If not, step up the ladder. Management of acute severe asthma. The best strategy for management of acute exacerbations of asthma is early recognition and intervention before attacks become severe and potentially life-threatening. Treatment starts with assessment of severity of attacks. Look for simple clinical severity indicators. This includes the degree of dyspnea. Can the patient finish a sentence? Degree of desaturation, paradoxic breathing, accessory muscles, mental status, silent chest, level of VBS derangement. It provides hypooxygen therapy to keep oxygen saturation below 90%. High dose inhaled short acting beta agonists are the mainstay of therapy, nebulized or via metered dose inhaler. Add inhaled anticholinergics if no adequate response. Start systemic glucocorticoids if there is not an immediate and marked response to an inhaled short-acting beta agonist. Slow infusion of aminophylline may be effective in patients not responding to high-dose bronchodilators. Make frequent every 1 to 2 hours objective assessment of the response to therapy until definite sustained improvement is documented. For patients with respiratory failure, it is necessary to intubate and institute ventilation. Consider antibiotics if signs of pneumonia. Refractory asthma. A small proportion of patients from 5% of asthmatics are difficult to control despite maximal inhaled therapy. Some of these patients will require maintenance treatment with oral corticosteroids. The most common reason for poor control of asthma. Thank you.